we'll have better version. Okay.
Okay, sir.
And Devika, did you switch on the recording?
Yes, she did. She did.
Okay, okay, sir.
It appears. Right.
Okay, carry on.
Good evening, everyone. I am Kavya, final year MBA student from Maharaja Institute of Medical Sciences, Vijayanagaram. Today, I am going to present a case regarding hereditary spherocytosis. A 13-year-old male, M. Yugandhar, second born of non-consanguineous marriage, native of Nerimala, Vijayanagaram. Reliability is fair. He was bought by his father with a chief complaint of yellowish discoloration of eyes noticed since 3 years, intermittent episodes of exaggerated yellowish discoloration of eyes, along with early fatigability with pallor, with recent episodes occurring since 2 months prior to the current hospital admission. History of presenting illness. Child was apparently normal till 3 years of age, at which he developed yellowish discoloration of eyes. There was no history of fever, nausea, vomiting, or loss of appetite prior to the onset of yellowish discoloration. No history of hematemesis, melena, or abdominal distension, or any altered behavior. Child has apparently normal pigmented stools, no change in color of the urine. He was treated with native medications. The intensity of yellowish discoloration came down, but still was persistent. At age of 8 years, there was worsening of this yellowish discoloration, along with easy fatigability and pallor. No history of fever or bleeding manifestations. No history of any drug intake prior to the onset of this complaint. No history of red-colored urine. During this episode, child was admitted to the hospital and was given 1 unit of blood transfusion. No history of pain in the legs, abdominal pain, or any swelling of hands and feet. No history of palpitations or breathlessness at rest or swollen feet. After the transfusion, the general condition of the child is improved. The latest episode starting 2 months prior to the hospital admission with increase in jaundice and progressive pallor. Past history, no history of any tuberculosis
Just a
or
minute.
bronchial
Just a
asthma.
minute. We will go back to the first slide.
Okay, sir.
At the outset, better not tell the diagnosis, right?
Okay,
Either
sir.
in the exam or in such cases. You are taking off the curiosity or the focus once you tell the diagnosis. Okay, we shall not get any, not only in the final year, MBBS or MD or DM. Okay, right. Okay.
Okay, sir.
Next. Next slide. Next slide. Okay. So, can you tell what could be the cause for EG fatigability?
So easy fatigability maybe because of anemia, sir.
Right. Good. The EG fatigability occurs when there is hypoxia to the tissue. Right.
Yes.
It can be either because of low oxygen carrying capacity, or it can be because of decrease in the intravascular volume that results in decreased perfusion to the periphery, in turn causing hypoxia. So, EG fatigability, even though it looks, it is a red flag symptom. Red flag symptom is very important symptom to be looked into. Previous slide. Previous slide. And in the same sentence, you mentioned the child was having pallor. So,
Yes.
when put together, there is EG fatigability and pallor in otherwise stable child, the inference is the child must be having significant anemia, right?
Yes, sir.
And are you very sure the child was normal up till the age of 3 years? Probably they would have noticed the child would have had the symptom prior to that also.
Okay, sir.
Why did you ask for history of fever, nausea, vomiting, loss of appetite?
So there is
Prior to,
yellowish discoloration of eyes. So
huh?
jaundice, maybe any hepatitis A infection, may be present in the child, which may
Not
lead
very-
to.
when you are not very sure, don't give the finer detail. It would have been better if you had said hepatitis, acute hepatitis. Acute hepatitis is mostly due to hepatitis A virus. Of all the hepatotrophic viruses, it is the hepatitis A that is caused. Hepatitis B will not have acute presentation. By eliciting that there is no history suggestive of infection, that is fever, nausea, vomiting, loss of appetite, these are the prodromal symptoms for acute hepatitis, generally because of hepatitis A. You would like to exclude this being because of infection. Okay. So in the
Okay.
history, the purpose of history is to weed out some important common condition, the probability whether to include or exclude. That is the purpose with which you have a detailed history. Why you are asking for hematemesis, melena, abdominal distension, altered behavior?
So jaundice may also can be even any extra hepatic cause to rule out any portal hypertension. So in case of portal hypertension, also chronic blood loss may lead to anemia. So in such cases, maybe hematemesis, if present, then we have to rule out any extra uh, hepatic
So,
cause. So I asked it for hematemesis early
yeah,
morning.
okay, you are right. First thing is there is pallor. Pallor, when it occurs, you have to rule out whether there is any blood loss. Basically, it may be simple hookworm infestation also. So, for the causes of the pallor, you want to elicit one by one, exclude it. If there is chronic hemorrhage, right, from the GIT, it may cause pallor. Right. The other cause is because there is jaundice, you may expect some liver cell failure or signs of portal hypertension, which you have mentioned. But the child was having persistently, so the chances of it is less, especially when there is no abdominal distension. Why did you ask for altered behavior?
In case of any liver cell failure, altered behavior, and abnormal behavioral changes.
There is acute hepatocellular failure. One of the earliest symptoms are altered behavior. Good. Next. And others also can unmute and answer. It's not that she alone is responsible for answering my questions. Next. Next. By eliciting that the child has normal color stools, no change in color, you would like to say it is not due
Any
to
conjugated bilirubin.
good. So you want to differentiate. Once there is jaundice, you would like to differentiate whether it is because of infection or some other cause. Infection you have excluded. Now that the jaundice is, biochemically speaking, hyperbilirubinemia. You want to know whether it conjugated or unconjugated. Once the stools are normal and color of the urine is normal, you can practically exclude diseases causing conjugated hyperbilirubinemia. And native medication you ask because they themselves can cause liver cell damage. Okay.
Yes.
Some drugs also likely to cause, but this is a long history. That's why you are right in eliciting, but such a long history generally we don't think in terms of drug intake, and the patient themselves they may stop with that because the history is spanning for nearly 10 years. Right? You can ask. History of red colored urine ask for
So G6PD deficiency. So after taking any drug for red
what will
colored.
happen in G6P deficiency. There will be
Uh,
hemolysis.
yeah.
Okay. Once there is hemolysis, there will not be red color. Only hematuria, blood loss only will result in red color. Fine. Previous slide. Why did you ask for pain in legs, abdominal pain, swelling of the hands and feet?
So when it is unconjugated jaundice, it may occur due to any of the intrinsic causes, sir. I mean, membranopathies or hemoglobinopathies. So, in case of sickle cell anemia, usually there is
Very
a
good.
pain in the
Very
legs or abdomen.
good. Good. Then why did you ask for palpitation, breathlessness, and rest? Or swollen feet?
So, anemia, I mean, chronic anemia may cause cardiac failure, so congestive cardiac failure.
Good.
So, the symptom of
That
congestive cardiac
breathlessness,
failure, palpitations,
breathlessness, anexation is also significant. No issue of palpitations, breathlessness,
Okay.
or swollen feet. They are suggestive of cardiac decompensation or heart failure. So once there is transfusion, the general condition of the child improved. What does it indicate? In history and examination, every point is valuable. It adds a lot of information. What do you infer? With simple transfusion, the general condition has improved.
So, after transfusion, RBC are usually given. So, anemia can be corrected in this case.
So just because transfusing more RBC with better hemoglobin, the general condition improved means the most of the symptoms are because of the anemia. Okay, good. Next. Ma'am, that's Sunita, Professor Sunita, right? Your inputs.
Sir, she's done a good job. I'll let her continue, sir. I'll come in like a later point.
Right. Next. So we need not ask something which is not relevant to the case, even in the past history. So tuberculosis causing jaundice is very unusual. Unless in late stage, it will be progressively going down. Bronchial is not required. Gallstones, yes, you may ask because prolonged jaundice. Okay, next.
Family history, non-consanguineous marriage, history of similar complaints present in the father. Father has a similar history of yellowish discoloration of eyes along with pallor and a mass in the left side of the abdomen. No history of transfusions present in the father. No history of gallstones. No history of any abdominal surgery, splenectomy or cholecystectomy present in the father.
She has, you are Dr. Devika, is it?
Kavya, sir.
Kavya, okay. So so Kavya has done a right thing by depicting pedigree chart. We call this as pedigree chart, which details about disease conditions in successive generations. One has to depict the detail over 3 generations. Good. And what would be the cause? What is your inference from this pedigree chart? Some things may be beyond failure student to answer, but since you are doing good job, I am forced to ask a little questions of a little more higher standards. What's your inference? Father had similar complaint and
Maybe father had a similar history of jaundice and pallor, or the left side of the abdomen there is a mass.
what does
So
it
maybe
indicate?
any inheritance, so
It
any
is
family inheritance.
inherited condition. Good. Next. So this is important. You will get from each and every point you elicit. Next.
Kavya, can you tell some commonly inherited hemolytic anemias? The mode of inheritance of hemolytic anemias?
Yes, ma'am. Usually membranopathies uh, hereditary spherocytosis and eleptocytosis usually have an autosomal dominant kind of inheritance now. Autosomal recessive kind of inheritance is usually seen in case of thalassemias and sickle cell anemia. And X-linked recessive kind of inheritance is usually seen in case of G6PD deficiency and hexokinase deficiency.
Okay, good. Go on. Go on.
Antenatal history, marriage at 21 years of age, conceived after 1 year of marriage, pregnancy confirmed by urine pregnancy test, booked pregnancy in local hospital in Vijayanagaram, had 4 antenatal visits, took iron and folic acid tablets regularly, no history of fever or rash, no history of any blood transfusions, no history of any preeclampsia or eclampsia or gestational diabetes mellitus or hypothyroidism, antenatal scans were normal, TIFA scan were normal, 2 doses of tetanus TD taken, and no history of any bleeding or leaking per vagina.
Everybody is aware what is PD. What is PD? Okay. No, maybe I'm asking for a bigger thing. Tetanus TT prevents is a standalone vaccine that prevents only tetanus. TD is the better one than TT, which protects against tetanus and diphtheria. In whom it prevents?
Neonatal tetanus is prevented.
Yes, but the option we are giving to the mother. Okay, right. Next.
Birth history, single term male child, a normal vaginal delivery, weight is 2.5 kgs at the time of delivery, cried immediately after the birth. Breastfeeding is initiated within 1 hour after the birth. No history of any prelacteal feeds or feeding difficulties. No history of any NICU admissions. No history of any neonatal jaundice or no history of any neonatal seizures.
By this, Dr. Kavya is trying to exclude whether there is any birth history. And she is sending a message that breastfeeding is to be initiated at the earliest, just within 1 hour after birth, very essential to have the benefit of colostrum to the baby. And prelacteal feeds means one shall not administer anything other than breastfeed even before the initiation of the breastfeed. They shall not be given. That's what she wants to tell us by this. And what is the purpose you are asking for neonatal jaundice in the neonatal?
So neonatal jaundice, usually two types of neonatal jaundice, either physiological or pathological. Usually, in case of hemolytic anemias, there is pathological jaundice usually present. I mean, from the first day of birth of the neonate, jaundice is usually present, sir.
From which day?
From day one. From day one, pathological
day one.
jaundice is usually present, sir.
If the jaundice appears on day one, practically it is pathological jaundice. Good. And this is one condition which may manifest with jaundice appearing on day one. Okay. That's why you are justified for the asking for the history of jaundice in the neonatal period. If it present, you have to ask whether it was there on day one itself. Okay. Next.
Kavya, can you elaborate on some causes of day one jaundice? Some examples of what is the more significant common cause of jaundice in the neonatal period? Pathological jaundice.
Yes, ma'am. Pathological jaundice usually occurs on day one, ma'am. It usually starts at day one within 24 hours. And in case of RH incompatibility or in case of any torch infections or congenital malaria, in case of any membranopathies or G6PD deficiency, pathological jaundice usually occurs within 24 hours now.
Okay.
It usually exceeds greater than 15 mg per DL in pathological and greater than 2 weeks in case of term baby and greater than 3 weeks in case of preterm baby. Ma'am.
Good. Go on.
Sepsis also, ma.
Okay, sir.
I joined late.
Okay, sir.
Yes, proceed.
Immunization history, immunized according to the national immunization schedule, sir.
Okay.
And the BCG scar is usually present, sir. Is present, sir, in this.
Just for a little correction, you say antenatal history, natal history, neonatal history, then development history. So it will be continuation from antenatal to natal, neonatal to development history. That will be in continuation. Okay. So after the neonatal history, you go for the development.
Okay, sir.
Next.
Developmental history, gross motor, fine motor, social and language, all our milestones are reached as per the age, sir.
So what we call these four are, they are the four domains of development which we would like to assess from the early infancy as the child grows. And if there is some delay in more than 2 or more, we call it as global development. Okay? And it's very difficult, essential to assess the development and growth of the child. The very purpose of taking the history in a detailed way is just because there is jaundice, you don't start of jaundice alone. You treat the child, don't treat the jaundice. Okay, that's very essential. And we don't wish it. A child may have more than one complaint. A child with such presentation may have, we don't wish it. developmental delay or growth retardation. So you have to have a comprehensive examination and history taking. Okay, that's why she has taken developmental history. Fine. Proceed.
Dietary history, sir. Dietary history is taken based on the 24-hour dietary recall method. The calorie intake of the person per day is 1430 kilocalories, sir. And the required kilocalories according to the age of the patient is 2020 kilocalories. So the deficit is around 590 kilocalories, sir.
Protein. The deficit is 17 grams. Okay.
Yes.
Okay. It is very good. But since you have gone for detailed dietary history, you may add deficit in percentages. That will be
Okay.
catchy. Okay. Out of 20 calories that are required, there is deficit of 590, say 600. Out of say 2000 kilocalories, 600 is deficit. So what is the percentage? That gives a better idea. At graduation level, it is not required, but you are going in detail of the dietary history. Okay, this also can be added. Okay, next. Right, you have gone through detail, but see that detailed history is essential when the child is having undernutrition. Okay.
Yes, sir.
Next.
Socioeconomic status, education of the head of the family is 4, income of the head of the family is 4, occupation of the head of the family is 7. According to the modified Kuppuswamy scale, the child belongs to the lower middle class families.
Yes. Next.
Summary, a 13-year-old child, second born of non-consanguineous marriage, presented with failure.
Just a minute. Because the history spans over 10 years, you may have a heading treatment history. Okay. If it is just 4, 5 days, 10 days, you may not tell much about treatment history. But the history spanning over 10 years, so you may give some information regarding the treatment. You have mentioned in the history of present illness, you can have a separate head, the treatment history. If there is some record, you can tell from the records if the parents are not able to tell you.
Okay. Summary, a 13-year-old child, second born of non-consanguineous marriage, presented with pallor and icterus 2 months with past history of similar complaints at 3 years and 8 years of age that required blood transfusion. Family history of similar complaints present in the father, immunized as per the age with no developmental delay.
So you may ask, of course, sometimes I am crossing the line of asking you more, but you may ask, what made the treating doctor to give the blood transfusion? It can be severe pallor, fatigue alone. Sometimes it is a pallor with signs of heart failure, like that. Okay. What necessitated blood transfusion? That also you may find out. Next. Because certain diseases, they may present with failure, certain hemolytic anemias or hemoglobinopathy. Certain hemolytic anemias, they don't present with decompensation, they present cardiac decompensation. They present with complications of the disease, like sickle cell disease, it presents with complications, not with a history of failure. So to control that complication or prevent the complication, blood transfusion will be necessary in child with sickle cell disease. Good.
Yes. General examination, child is conscious and active, pallor is present, icterus is present, no history of any, no signs of any cyanosis, clubbing, lymphadenopathy, and no pedal edemas.
Right. Okay.
Vitals, pulse is 96 per minute, regular, normal volume, peripheral pulses are felt, no radial or any radiofemoral delay. Respiratory rate is 24 per minute, BP is 110 per 70 mm of Hg, temperature is 97.6 and SpO2 is 99%.
So peripheral pulses are normally felt. Felt is different and normally felt.
Okay.
He is studying is different, he is studying well. Okay. And secondly, there is another one you may add, because this is stable child, it may not be required. Once you answer well, the examiner may be tempted to ask a little higher standard question. The another vital C data is CRT. You heard
Yes, sir.
capillary
Yes, sir.
refill time.
Capillary filling time. Yes, sir.
That also you mentioned. You score more by mentioning these things because you had been maintaining good standard. So you are expected to tell out more things. That's the penalty
sir.
one has to pay, being well prepared. Right. Not
Yes.
exactly penalty,
Kavya,
by that you will be given more marks. Right.
Kavya, where do you look for capillary filling time?
Capillary filling time is usually used in soles and palms. Usually the limb is lifted up to prevent the pooling of blood, and capillary filling time is usually
Very good.
normal capillary filling time is less than 2 seconds.
Excellent.
So, don't say, be more specific, not soles and hands, at the fingertips or in the toes. Okay. In the
Okay,
peripheral
sir.
part. Right.
Yes.
And make sure
Anthropometry.
the environment is not very cold. If the environment is very cold, like in the ICU, there will be some peripheral vasoconstriction. There will be delay in the prolongation of CRT. Okay. Right.
Yes.
Next.
Anthropometry. Weight of the child is 36.4 kgs, sir, and the height of the child is 153.5 centimeters. The expected weight according to the age of child is 43 kgs and expected height is 155 centimeters. So weight is between 10 to 25 centile and the height is 25 to 50 centiles. BMI of the patient is 15.5, sir.
Good. See, when the weight is a little less, you call it as underweight. Weight per age is less, you call it as underweight. Not in this child,
Yes.
generally I'm talking. And
Okay, sir.
it indicates acute undernutrition. Right? And height, if it is less than third centile, you call it as stunting. That indicates chronic undernutrition. Here, the undernutrition doesn't necessarily mean underfeeding. So the term, even though it is not giving you full picture of the growth, but the term is like that, so shortly it may be changed also. When BMI is less, you call it thinning. If it is more, you call it as obesity or overweight, and less, you call it as thin. The anthropometric measures give us a very good information about the growth of the child, especially when taken serially. There are what are called growth charts. If you plot the weight, height, and BMI on the growth charts, you will be knowing the pattern of the growth, whether there is any faltering, we can observe and attend to. So it's very essential that a child is
Yes.
to be look for this parameter. Good,
Growth chart of the child, sir.
good, very good.
Head-to-toe examination. Hair and hairline normal, sir. Face is normal with no frontal basing, no malar prominence, and no facial dysplasia. Skull is normal. Eyes, yellowish discoloration of the eyes is seen, sir. Ears are normal. Oral cavity, pallor is present, sir. No angular cheilitis or no angular no glossitis. No evidence of any cleft palate or palates. And tonsils are normal. Neck is normal, sir. Chest is normal. Abdomen is normal. No engorged veins are present. Skin and nails normal, sir. No cholionychia or no hyperpigmentation of the knuckles. Spine, no spinal deformities are seen, sir. Upper and lower extremes are normal.
Nice. Just because I am interrupting, that doesn't mean that not to discourage you, but I am expected to. Why did you ask about hair and hairline, especially hair and hairline? What do you want to infer from it, if there is some abnormality?
So in case, so in some iron deficiency anemia, there may be
No, it's not
alopecia,
like
sir.
that.
So
There may be abnormality in the hair when there is undernutrition. Okay, hair abnormality. Hairline will ask to know whether there is any associated syndrome. In some syndromes, there will be receding of hair. For that, we will ask. Hair to know about the undernutrition. And face, all these things. Now, why did we ask for brushing, frontal brushing, malar prominence?
So in case of hemolytic phases, frontal bossing, malar prominence, facial dysmorphism is usually seen.
See, none of
Hypertrophy
your
of the
None of your friends are helping you. Please, either you can unmute and answer, or you may type in the chat box the questions asked for. It is not just for her alone. So it is because of the why there should be malar prominence, frontal bossing, and hemolytic anemia.
Uh,
It is because of the widening of the deep flow, because of the increased erythropoietic activity. So when the erythropoietic activity is more, then only those things occur. Facial dysmorphism, you want to know whether it is part of dysmorphism. Where do you look for jaundice?
so jaundice is usually looked for bulbar conjunctiva, skin, and
How is it? Can you take off the spectacles and demonstrate for all of us how to look for?
okay, so
How to
the patient is asked to look down, and eyelids are usually lifted and checked for
very,
the
very good.
jaundice.
Very good. Why not just seeing and telling? Why all this? Okay, I'll tell you. In the interpalpable pressure, because of the exposure to the environment, there may be some discoloration of the bulbar conjunctiva, which may give the false impression that there might be jaundice. When you want to see a part which is not exposed to the environment, that gives a better idea. Where you will look for a pallor, just again demonstrate.
Failure, the patient is asked to look up and lower.
No, first you do, and then you ask the patient. First, what will you do?
The
You
patient is
demonstrate
asked
and you
okay.
demonstrate. So you have to use your both hands, pull the
Yes, sir.
lower palpebral down, then ask the child to look up. Let it be. Same for the adults and children. See, pediatrics is only general medicine of the children with developmental growth and congenital anomalies like that. So, elicitation of science practically same. Ears are normal, you would like to know whether there is any syndrome. Right. Tongue pallor present. Whenever there is pallor, in the history of in the general examination or head to examination, try to ascertain the cause for pallor. Here you know the diagnosis, you told us the diagnosis. But when we start examining the case, we don't know the diagnosis. So try to ascertain the cause for pallor in the general examination or head to examination. When the pallor is associated with jaundice, it's hemolytic anemia. Simple. When there is no jaundice, the pallor can be because of blood loss, acute or chronic. That is because of blood loss, that's why it can be anemic or pale. But in the absence of blood loss, if there can be anemia
Decreased
because of
productions. Decreased
nutritional
production.
deficiency. Yeah, nutritional deficiency which causes decreased production. Right. In hemolysis, it is the increased destruction. In hemorrhage, it is the actual loss of the blood. And in the absence of these two, you consider, you exclude one by one what are the probable causes. Easily excludable in any other cases. Absence of jaundice, it is not hemolytic anemia most likely, either from the history or from the physical examination. Then you ask for history of blood loss. If it is not there, so you exclude that class. Then you come to nutritional anemia. Nutritional anemia, how do you differentiate what could be the causes? You yourself mentioned. How do you?
Iron deficiency anemia and
It's uncommon. See, uncommon
medroblast.
will exclude first. Uncommon thing is B12 deficiency. How will you?
So
How do you know whether this
hyperpigmentation
is
of the
very
knuckles
good?
is usually seen.
Hyperpigmentation of knuckles. And
Um,
other side of macrocytic anemia. You mentioned oral cavity, glossitis. Loss of
yes, sir,
papillary.
glossitis. Yes.
So that is macrocytic anemia. They are not there. So it boils down to iron deficiency anemia and nutrition deficiency. Any pallor, you have to think in those terms and look for. And when it is long standing, you may appreciate signs of clinical signs of iron deficiency, which you mentioned somewhere. Carnage is not there. Okay,
Yes.
that you have to evaluate. We don't have another system for. We do GIT examination for hematological and renal conditions also. So the convention says like that. So for since you don't have any other system like hematological system examination, you try to identify the cause for pallor in the general examination itself. Right. Why did you ask for engorged vein?
So engorged veins, in case of portal hypertension, engorged veins are present.
Yes. It is not the visible veins that is pathological. It is engorged, right? Tortuous veins that are pathological, not simple visible veins. It may be because of wasting of the skin and subcutaneous tissue. Right. Next.
Gastrointestinal system.
Professor Sunita, her input. We will hear madam. Professor Sunita, you would like to add any inputs?
So we'll move ahead.
Right. Okay.
Systemic examination, gastrointestinal system, oral cavity, good hygiene, dentition is normal, failure is present, oropharynx is normal, shape of the abdomen appears to be normal, all quadrants of the abdomen moving equally with respiration, no evidence of any abdominal distension, umbilicus is present in the midline and is inverted, no visible sinuses and enlarged veins, no visible pulsations, post abdominal wall normal, hernial orifice is normal, genitalia normal, oral anal orifice normal.
So as she has rightly done, one has to start the examination of the GIT from oral cavity down to anal orifice. Right? That completes the comprehensive examination. For respiratory system, it is from the nasal flare down to the lung parenchyma. For cardiovascular system, it is neck, then comes the cardiovascular or the chest. Right. So we don't directly examine the abdomen in case of GIT. Right. So you may mention about the presence of papillae also in the examination of the oral cavity. By that we are saying it is not macrophatic anymore. No visible pulsations or peristalsis. Now we are examination of GIT. That's why we are more interested in examination of visible peristalsis that is connected to GIT. It's a very good practice which is not seen even postgraduate clinical case discussion is examination of the posterior abdominal wall. Right? Very good. Abdomen is not just on the anterior side, it's also posterior side. It's a very good practice you mentioned. Posterior abdominal wall also. Good. And not to forget the genitalia. We have the privilege of examining at least male children with knickers down up till the mid-thigh and examine the genitalia. If you don't do it, you may miss some cases. Very important being, what is the condition which you may miss if the genitalia and genitalia are not examined? Right,
So
I'll
in case
tell
of
you.
gender.
It is too much I'm asking, I know. Undescended testes. Unless you operate or bring down the testes into the scrotum by 6 to 9 months, the child may go into not only testicular atrophy to malignancy also. Some urethral abnormalities also we may miss. Next. Anyway, in
Palpitation.
the general examination, we may go for SMR. Okay, SMR is sexual motility rating. You may not be asked to present the stall order, but still just to add on. Okay, next.
Okay. Palpitation. All inspected findings are confirmed. No local rise of temperature. Soft, non-tender spleen is present. Grade 3. Smooth surface. Splenic notch is palpable. Firm in consistency, sir. Liver is palpable. 2 centimeters below the right costal margin. Soft, non-tender. Smooth surface. Rounded margins. Moves with respiration, sir.
Okay. So you have rightly done. See, most of the times we do cephalocardally. The examination, anything which I was mentioning, oral cavity to anal orifice, nose to the lung, down to the parenchyma, neck then followed by chest in the cardiovascular system. What we are doing is examination in the cephalocardal way. See, right from anatomy days, we do anything we do in a cephalocardal manner. When you are examining the abdomen, it is from superficial to deep. First, you look for localized temperature. Then you comment about the skin and subcutaneous tissue, insignificant undernutrition. Skin and subcutaneous tissue, they will be wasting. In conditions like nephrotic syndrome, there will be edema of the skin. Okay. By that you will be knowing it's a significant hypoalbuminemic condition. After skin and subcutaneous tissue, we examine whether the abdomen is soft. Once it is soft, you can practically exclude any acute peritonitis or intra-abdominal infections. And attendance also says there is no acute condition, especially when it is not there on the, or the abdomen in general, more so on the viscera. And it is a convention to examine nothing wrong by saying spleen first and liver. Just we follow some convention. First describe the liver and then go. Nothing wrong if you do it otherwise also. Liver is palpable to wow. Probably it may not be soft. Why I am saying probably it is not soft? Without saying I shall not talk, but still I am saying probably it is not. The reason is that you will find soft hepatomegaly in acute conditions, like acute viral hepatitis, endemic fever. Right? Whenever it is acute, the enlargement is only soft hepatomegaly. But ours is not an acute condition. It's spanning over 10 years. You don't expect the liver to be soft with some disease for over 10 years. The most likely the liver probably will be formed. Okay, but never say hard. Hard indicates malignancy. Never means in the sense malignancy is very uncommon. That's why I'm saying never means it's not a rule that so generally don't go for hard consistency. When it's long history, generally it will be warm. I'm talking about the liver, right?
Yes.
And you may be asked in the exams, why do you say it is liver enlarged?
So,
Why do you think it is
in case
hepatic
of hemolytic anemia, mostly hepatosplenomegaly is seen.
not that way. When we are discussing a sign, you have to say why it is, why you are saying. We are confined to the particular excitation of that sign. Why do you think it is liver enlarged or enlarged liver? One, it is moving with restriction, right? That means it is attached to diaphragm. Number two, it is superficial. Liver is a liver and spleen are superficial viscera in the abdomen, unlike kidneys, which are retroperitoneal. They are also attached to diaphragm, but they are retroperitoneal. These are superficial. Third, it is in the topographically, it is the anatomic position where the liver is accepted to be. That is right hypochondrium or part of the epigastrium. Right? That's why you are called, and you are feeling two lobes. When it is enlarged, you can say right lobe and left. And there is a margin, there is an edge. That's why you call it a liver, enlarged liver. Okay. And spleen, first of all, you tell what is the size. Okay, grading is also good, but like liver, you tell about the size below the left costal margin. For right costal, for liver enlargement, you see the measure the enlargement in which line? Mid-clavicular line. Okay. For spleen, because liver enlarges down. That means from the right hypochondrium into the lumbar R and R umbilical into the right iliac fossa. That's why you examine vertically. Whereas spleen enlarges, when it enlarges, it obliquely enlarges. That's why you have to measure the splenic enlargement in the long axis of the enlarged spleen. Long axis, you understand? When it is like this, you do it in the lengthwise, in the long axis you measure, you may tell in centimeters. Then you may grade it. And why do you say it is spleen is? One is it is moving with respiration. Two, superficial structure. Three are the first one actually. It is the left hypochondrium, and you are feeling a splenic notch. You have rightly said the consistency. expected to be unease, home, because it's a long-standing disease. Okay, you have to tell them why do you think it's your liver or spleen. You have to tell like that, not from the end point to the end. Mathematics లో ఆన్సర్ నుంచి ముందుకు రాకూడదు. అలాగే ఇక్కడ కూడా అంతే అన్నమాట. The diagnosis is expected to be arrived at the completion of examination. హెమరాటిక్ ఎనిమియా అలా ఉంటుంది కాబట్టి ఇది ఎవరు స్ప్లీన్ కాదు. ఇవి రెండు ఇలా ఉన్నాయి కాబట్టి అది హెమరాటిక్ ఎనిమియా అయి ఉండొచ్చు అని. ఓకే, అండ్ న్యాచురల్లీ any viscous which is foam will not be tender. Only soft livers are likely to be tender. Good. And you may say there is no other mass palpable. We don't wish it. In some conditions, there can be visceromegaly, enlargement of the knee and or liver, or both with some other mass, like lymph node mass or upward momentum, like. Okay, there is no other mass. And you inspected the posterior abdominal wall. The same way you palpate the posterior abdominal wall, specifically at the renal angle. In the observation whether they are full, that is inspection. In palpation, you look for any tenderness in the renal angle. Okay?
Yes.
Yes.
Question, sir. No evidence of any free fluid in the abdomen, and liver span is 12
When
centimeters.
you are describing, you have to tell what is your observation. No evidence of free fluid is inference. You don't give inference. You tell what you examined and what is the result of the examination. You focus and you heard tympanic node or resonant node. The inference is there is no free fluid. We don't give the inference first. You tell what you did. That is on percussion. The note is tympanic. Tympanic, why it is tympanic? Accepting over the enlarged liver and spleen, naturally. Right? Why? What does it indicate when it is tympanic node? Tympanic
No
node heard
fluid is present.
over, no. In a gas-filled vessel. So intestines are filled with gas. That's why you heard you will have a tympanic node. The same resonant node in the chest, we call it resonant node because it is covered by the alveoli. Right? So that resonant node is different and tympanic node is a little bit of subtle difference. Level span, it is a good practice to measure, but when there is no abnormality in the chest, you may not mention it. Okay, that is
Okay.
purpose of knowing the assessing the level span is to know whether it is pushed down liver because of some intrathoracic disease or hepatomegaly itself. Now, from the history, it is apparent there is nothing pertaining to chest disease. So it's unlikely to be pushed down liver. It is enlarged liver. When you have that conclusion, you may assess the liver span. But nothing wrong in assessing, but fine. It's a good practice. Next.
Auscultation, normal bowel sounds are heard, sir.
Bowel sounds are heard. Normal in frequency and intensity. Bowel sounds are heard in normal frequency and intensity. Right.
Okay.
Next.
Other system examination, respiratory system, no nasal flaring is seen. Trachea is in the midline. Chest bilaterally symmetrical. Chest movements are equal on both sides. No retractions are present. Bilateral, normal vesicular breath sounds are heard with no adventitious sounds present.
Very good. Very good. So rightly you have started from the nasal flare down to the right. And the second system of importance in this case is primary symptoms. Of course, even though it is hematological disease, we examine under the head of GI. What is the second relevant system?
Serious.
Huh?
Serious. Cardiovascular system.
See, even at this age also, I don't use short form. S1, S2, I don't use CVS, I don't use. So it should be a practice to tell full form. Even at this age also, I say cardiovascular system, first and second half, stuff like that. Okay, it's a good practice. Why cardiovascular system is more relevant?
So in case of anemia, they may be considered cardiac failure, so they may be seeing any cardiac manifestations.
Wonderful. In initial stage, it may be hyperdynamic circulation. Unless it is not corrected, it may go into congestion, heart failure. Why congestion? Heart failure. It can be either side. That's why the second system could be cardiovascular system. Right. Next.
Cardiovascular. So,
Probably
central nervous system, child is central nervous system, child is conscious and coherent, cranial nerves are normal, motor and sensory system normal, cerebellar system is normal, no signs of any meningeal irritation, and spine is normal.
whenever you are examining anything, you always should know what is expected or likely there. With that focus, we have to examine. When you examine cardiovascular system, what for you will examine? Signs of hyperdynamic circulation or cardiac decompression.
White pulse.
Heart failure. Okay. You should know. You think about the primary disease, what is its repercussion on the other system. And think of the primary disease, its complications, what are the manifestations in the other system. So primary disease is something, manifestation is, the complication is hyperdynamic circulation, then heart failure and its manifestation. When you are examining or eliciting history, you should have a clear idea what you are eliciting in the history and the physical examination to specifically. Unless your mind thinks about your eyes and hands, not be able to elicit. So when you examine like CNS, one thing you would like to examine in CNS, if not exactly in this child, in any child with jaundice, severe jaundice, what is the one which you look for in CNS? That we should know, and you will be focused on that. See, you don't expect any, you have to mention all, but you are not very focused on that. One thing is, you have mentioned in the history itself that you want to know whether the child is going into pre-coma. These children with this jaundice, they will not go into. But in a child which is presenting with fever, vomiting, abdominal pain, right, loss of appetite, jaundice, yellowish urine, they will go into acute hepatocellular failure. Why these children will not? So you have to look for signs of early signs of hepatocellular failure. Why these children will not go into that hepatic encephalopathy?
So no signs of any. So
Yes,
no
they are on
signs
the track. Yes, there are no.
signs of and it is a conjugated nodules, so pre-hepatic
Not that way. Not
cause.
that way. See, in acute hepatitis, for example, it is the disease of the liver. Hepatocellular damage is there. Hepatocytes are damaged. Liver is damaged. So the function is less. So when the function is less, the accumulation of metabolites may reach the brain. Even though there is jaundice here, even though the liver is enlarged, is the liver primary disease? No, it is not primary disease. Hepatocytes are doing good job. That's why in between there is clearance of the jaundice. There is no hepatocellular failure. There is no hepatocyte disease. Liver is not primarily disease, unlike disease of the liver with hepatotropic viruses like hepatitis. So these people will not go into hepatic encephalopathy. But you should know for the patient, and in the exam also, the examiner will be very impressed. You know what to look for in cardiovascular system. That is hypertension, heart failure. What to look for in CNS. That is, even though this doesn't occur, but impress upon the examiner that I know what to examine in a child with jaundice. Good. Next.
Cardiovascular system, sir. Apical impulse is felt in the left fifth intercostal space, 1 centimeter medial to the midclavicular line. Uh, First and second heart sounds are normal. No cardiac murmurs are seen, sir.
So what is your inference? Apical impulse is in fifth intercostal space, 1 centimeter. Is it normal?
Yes, sir. Apex is in the correct place. So apex is not shifted. There is no any cardiomegaly. And
Very good. You preempted my question. You know what is preempting? What I'm going to ask you, I have answered. So there is no cardiomegaly. Cardiomegaly is due to why there should
increased overload of the heart, volume overload.
okay, it is volume overload. What? Why there is cardiomegaly? What is happening anatomically?
Enlargement of the left ventricle may cause shift in the apex.
Okay, I'll put it in a better way. There are two ways. One thing is hypertrophy, another is dilatation. That's the pathological process that occurs in a ventricular disease. Whenever there is hypertrophy, there will not be any cardiomegaly. In your pathology textbook, if you remember Robbins and all, they give the cross section of the ventricles when they are hypertrophy. The hypertrophy occurs concentrically at the expense of the chamber. That is hypertrophy. That will not result in cardiomegaly. Whereas dilatation is the one, it is a decompensated state. The chamber is dilated. That only causes cardiomegaly. Right. You have done answer well. And do you expect any murmurs when the child is having severe pallor? The child is not having heart disease, primarily no heart disease. But can you hear any murmurs, any auscultatory findings? I wish others answer. There is a, you can answer in the chat box. Okay, I'll tell you. Whenever there is hyperdynamic circulation, when there is severe anemia, it results in hyperdynamic circulation. When increased flow of blood occurs along the valve rings, it may generate a sound that is murmur. This is hemic murmur we call. If you put your stethoscope on the large vein in the neck, you will hear a venous hum also. Right. Next.
Investigations, sir.
No, before going to investigation, we have to tell the clinical diagnosis. In the examination, either you or postgraduates are asked only to tell the clinical diagnosis. Most of the times, the examiners stop at the end of clinical diagnosis or some differential diagnosis. Lab diagnosis is not required even at the postgraduate level, but for completion's sake, you may tell. So, what's your clinical diagnosis?
So, clinical diagnosis, a case of hemolytic anemia, probably hereditary spirosis, sir. I mean, the first differential, according to the history and examination, the first differential is hereditary spirocytosis, sir. And the second differential may be thalassemia intermedia also, sir. But according to the presentation, in thalassemia major, it is greater than 2 years of presentation. And this particular child usually have a family inheritance. The father is having the same. So I guess it is probably a case of hereditary spirocytosis, mainly in case of inheritance.
Okay. We'll come like this. There is pallor. Okay, definitely. And it is getting corrected with blood transfusion. That means there is less hemoglobin. Otherwise, clinically, it is pallor is clinical term and anemia is pathological corroborative finding. So there is anemia. Then, is it nutritional or hemolytic? Hemolytic anemia. Why do you say there is pallor and jaundice? That's why hemolytic anemia. So it is a child with hemolytic anemia. Then what type of hemolytic anemia? It all depends the
So
way it is present. See, we say transfusion dependent and non-transfusion dependent. If it is transfusion dependent, frequent transfusions are required, you call it transfusion dependent thalassemia major. So that's why you are not saying thalassemia major because it's not transfusion dependent. One or two transfusion doesn't make it transfusion dependent. So either it can be non-transfusion dependent, thalassemia or sickle cell anemia or broadly hereditary. These are the three important things. This is not thalassemia because this is not sickle cell anemia because the child never had complications of sickle cell disease, like intractability, abdominal pain, stroke, any crisis, nothing is there. So it is not sickle cell anemia, even though that is up. Then comes thalassemia. It is not major because not many interactions are there and present. Late. It can be thalassemia intermediate or minor. Minor clinically is difficult to identify. It doesn't manifest significant joint. So once it starts very early in the life, and when the father is also having, it's a hereditary hemolytic anemia with splenomegaly and some hepatomegaly. The first choice goes to hereditary spherocytosis. You also have nicely narrowed down to the diagnosis. Now we will go for, and you have to mention whether there are complications. Whenever you are telling a clinical diagnosis, it should be comprehensive about the primary disease and also any complications. Right? What are the complications one may encounter with hemolytic anemia? Jaundice is not a complication; it is part of the disease because hemolysis is occurring, jaundice is there. Okay, the important complication we look for is whether there is a heart failure. You may say a case of hemolytic anemia. You need not say probably completely clear hereditary spherocytosis without heart failure, with normal nutrition, no micronutrient deficiency. That makes a very comprehensive clinical diagnosis. You are not expected to tell so comprehensively. Now that you presented so nicely to the standards of a postgraduate, that will be the comprehensive way of putting the diagnosis. It's not the disease alone you treat. The diagnosis pertains to the entire body. That is the take. That is the message I want to convey. It's not the disease alone you treat the child. Right? That's why you have to describe it so vividly. Next.
So next is the usually I kept this laboratory diagnosis of the investigation peripheral smears.
Good, you are giving the comparison. Right. Okay. Hemoglobin A8 is 4.2. Yeah.
Can you read out and interpret the report, Kavya?
Yes, ma'am. Hemoglobin of the child is 7.2 gram per dl. RBC is 2.53
Ma'am is
milliliter,
asking
and
for
MCV is
interpretation.
70.
7.2, you call it as anemia. Ma'am is asking for interpretation, not
Yes,
reading.
yes,
So the child is having anemia, father
yes,
is also having anemia. Okay.
yes, sir. And the MCV is slightly low, sir, because the normal level of MCV is 80 to 100 femtoliter. MCV is slightly low. MCH is normal, sir. MCHC has increased. Normal level of MCHC is 32 to 36 gram per dl. It is 38.4, so MCHC is usually increased. Packets according is okay. Coombs test is negative, sir. No any antibodies against the RBC. Osmotic fragility is increased, sir. And here in HB electrophoresis, HbA2 is increased, sir.
Okay.
HbA2 level.
Good.
Reticulocyte count is increased, sir.
Osmotic fragility test is one thing which is very much suggestive of it being hereditary spherocytosis. Reticulocyte count, what happens in hemolytic anemia?
Increases, sir. Reticulocyte count
Naturally,
increases.
because there is no problem now got the micronutrients that are required for erythropoiesis in nutrition deficiency anemias, because there is no availability of the required micronutrient. The RBC count will be low, reticulocyte count will be low. Okay, next.
Peripheral smear of the child, sir. Shows anisocoiculocytosis, predominantly microcytic hypochromic RBC, red blood cells with microspherocytes are seen, suggestive of hereditary spherocytosis.
Why do you say there are spherocytes?
So round shaped RBCs are present,
Yeah,
sir.
they are also round, but they are spherical. Round is different,
Yes,
spherical.
spherical.
Spherical is round in all directions. Round is, it can be single direction like any other normal RBC. In the appearance, why do you say it is not normal RBC?
So MCHC is increases, sir, normally.
When we are talking about purpose smear, you talk about purpose.
Okay, sir.
On seeing the RBC, why do you say it is spherocyte? Just think and focus and listen, you will know it. Medicine is just thinking. Think, analyze, correlate, you'll get the diagnosis. See, there is no central clearance in normal RBC. There will be central clearance. Here, because of the spherical nature, there is no central. You got my point? Okay.
Yes.
Next.
Peripheral smear of the father, sir. shows mild anisopoikilocytosis, predominantly microcytic hypochromic red blood cells with microspherocytes are seen, suggestive of hereditary spherocytosis.
Okay. So it's always good habit to not only examine the child, but also when especially the symptoms and history is suggested, examine the parent as required or siblings as required, depending on the presentation of the case. Very good.
Yes.
Next. That's it, is it?
Yes.
One more slide is there. One more slide is there. Now we are 29th slide. Thank you.
Yes.
So, I asked you and make you say thanks. Right. Okay. Right. And a big clap for Ms. Kavya. She has done in a very, very nice way to the standards of a postgraduate. Very good. And very well mentored and groomed by Dr. Professor Sunita. I can see her through your presentation. Right? She very well mentored. Right? Very nice. Wish you all the best. And I'm very sure if you have a gold medal in pediatrics, you are a first candidate probably to get the gold medal because your way of presentation is good, analysis is good, answering is good. Well done.
Thank you. Thank you.
Professor Dr. Sunita,
Sir,
now.
sir, can we end the session, sir?
Yes, that's what I'm telling. It's now.
Yes,
Thank you, sir. Thank you very much, sir, for the insights. Thank you, madam.
Thank you, sir.
Okay. Well
Thank
done. Right.
And excellent job, Kavya. You've done a wonderful job. Very
Yes,
well
ma'am.
done.
Thank you.
Right. Nice. You are taking very good pains, sir, in organizing some things for the benefit of the student.
Okay, sir.
God bless you for your services. Right.
Sir, thank you, sir. Namaste, sir. Devika, we'll close the session with Shanti.
Yes, sir. सर्वे भवन्तु सुखिनः सर्वे सन्तु निरामया सर्वे भद्राणि पश्यन्ति मा कश्चित् दुःखभाग् भवेत् ॐ शान्ति शान्ति शान्तिः थैंक यू एंड చేసేనా సార్